In terms of getting going, I'd like to go around the table and have everyone say who's here, and then also we'll check to see who's on the phone. Julia Chilko, HSCRC.
Steve Ports, HSCRC.
Ray Gray.
Mike Robbins with the Maryland Hospital Association.
Kristen Polio, Adventist Healthcare.
Mike Brady from University of Maryland Medical System.
Paul Parker, Maryland Healthcare Commission.
And Hugh Strutman, Maryland Healthcare Commission.
Jim McGee, Transit Employees Health and Welfare Fund.
Ron Hamper, Care First.
Stu Gutterman, Commonwealth Fund.
Claudine Williams, HSCRC.
Donna Kinzer, HSCRC. And on the phone we have Ann Mack. And do we have
David Johnson with Simpson Consulting.
Do we have Mike Curran?
I'm here. Good afternoon.
Good afternoon, Mike. So, so I think that
Dan Dorn from the Urban Institute, working with Maryland Healthcare for All.
Excellent.
Hi, Steve Kravitz from Johns Hopkins Community Physicians.
And do we have anyone else? Excellent. In terms of our meeting today, we have a number of topics that we're going to focus on. First of all, we're going to review the cost of care template that we've been working on with the payers in terms of being able to collect cost information outside of hospitals. We went over a paper at the prior payment workgroup meeting on GBR corridor and corridor relief. It's GBR and TPR, but global budget corridor relief, and we just wanted to check in with folks on that that document. Shuli's going to give an update on the transfer policy and the work that we've been doing on that, and then last but not least, to start through discussing guiding principles for market share policy and discuss where we are in terms of data analysis on market share policy. So that's our plan of attack for today. And with that, we'll turn it to Claudine.
Hello, good afternoon. I'm here to talk about the total cost of care template that we've been working on for several months. This PowerPoint was sent out this morning, and it's also included on your packets on your desk there. So the purpose of the total cost of care reporting, CMS requires us to monitor total cost of care, particularly for Medicare per beneficiary total payments as a guardrail, and then the all-payer total cost and the shift to unregulated services. So the intent was always to use the MCDB going forward because it's a more robust data set in the long term. But initially there were some reservations about this data set, particularly around the timeliness of the data, and then also potential gaps such as in covered segments and then some carve-outs. So as part of the data and infrastructure work group discussion, as well as from white papers, the suggestion was to recommended collecting claims, aggregate level claims data voluntarily from major payers to monitor the total cost of care and also the shifts to unregulated space.
And while moving on, just clarification, MCDB is in private payer claims collected by Maryland Healthcare Commission. So the idea was to use the claim level data to create the total cost, but with the recommendation it was suggested to do an aggregate level of reporting separately in the meantime.
Right. So So the guiding principles that the data and infrastructure work group members came up with was that it had to be simple enough to minimize reporting burdens on the payers. It has to have clear definitions to ensure consistency across reporting, build on existing and well-documented models and data definitions so findings can be correlated and validated by other data sources, sufficiently disaggregated and comprehensive to be able to trend the all-payer cost, understand shifts from regulated to non-regulated settings, and then be able to look at the underlying cause of those shifts, whether it be related to changes in coverage or to health status. So we've had some progress in developing the total cost template. We had several voluntary payers that will voluntarily report, including Medicare will provide data on a quarterly basis. Medicaid is providing data on an annual basis for the MCO and fee-for-service folks. But the commercial insurers have been reluctant to supplement or duplicate the MCDB reporting due to resource constraints. So after some conversations with MHCC about their MCDB, it seems like, or it looks like the timelines for this database will be expected to improve. The supplement data available through this MCDB with Medicaid and with Medicare should be able to produce, we should be able to produce the total cost of care report. And then below is the timeline. So currently they have calendar year 2013 data in its raw form, but they plan to have additional value-added variables added by December 2014. And then for the calendar year 2014 data, the raw data will be available in May of 15. Raw data with 1 quarter of runout will be available in August of 15, and then the reconciled data with the 1 quarter of runout with the value-added variables will be available at the end of September of 2015.
Could you explain what runout and added variables means?
Right. So the runout, because of the way they're collecting the data, and we have a representative from MHCC here who can speak to it if I'm not correct. The way that they're collecting the data is based on the date that it was paid. So for that 1 quarter of data that's coming in 2015, we'll still have some claims from 2014. So to be able to get all the claims, we just need that 1 quarter. And then there's some value-added variables, and I'll ask my friend from MUCC to speak to that, that their processing vendor adds to the data set to make analysis a little easier. So go ahead.
But we have a vendor that actually clean the data and have some added variables that we could actually get information more readily from whether we use it from a stats perspective or some other tool. So it will be readily available, not using the raw information. So that will, there's a lot of flags that we actually use to actually have a more faster processing for family planning.
So it would make it a little easier for analysis purposes.
Correct.
So if we are doing the total cost of report, you said clean. So the one that will be available in August, is that the cleaned version or is it as submitted, whatever is submitted in August?
This is, in August you'll have 1 quarter of runout. So in other words, that would be 3 months of runoff from prior incurrals.
Right, but the data that's available in May would already be cleaned. Is that correct?
That is raw data without the added variables.
But is it cleaned?
The way that Linda said to me that it isn't reconciled across all quarters, so it's pretty much exactly what the payers submitted, but then the data that's available in August is reconciled across quarters. It has the value-added variables, so it's a much...
so the timeline...
I mean, I'm sorry, in September.
Right.
I'm sorry. Yeah, so the September data would have all the it will be reconciled across the quarters. It will have the value-added variables, and it would be more processed data set.
And that'll be for calendar year 2014.
Yes.
So there is kind of, if we are looking for September, 9 months time lag.
Claims for calendar year or incurred through December 31st, and the run out, whatever the run out is, 60-day or 90-day run out. Well, for submitted, so is it incurred or paid? No, for each of these quarters, you have, it was based on pay date, so incurred any time and paid within that time period. So you're not getting all the incurred data for calendar year 14? Not as yet. Once you add up those quarters, and then you have the 5th quarter, then you have 3 months of run out for that 12 months.
So it's being converted to incurred based on the payer submission of paid claims are being converted to incurred date.
Are you backing out in the 1st quarter the incurred from the previous year? Or is it just paid days? No, it's paid, incurred any time, but paid within the quarter. So your 1st quarter then.
John, you back it out based on the date of service. So when you run your program to aggregate the cost for the year, you base it on the date of service. So that's how you. So it's up to the user of the data to specify whether they want incurred or paid, and so we would want incurred, and we would specify it based on the date of service.
Right. But if I'm reading this, it's really not until 9 months after calendar 14 year end that we know what the spend was, with the exception of 2 things. One, those payers that don't voluntarily submit the data, because there's even under the mandate, there'll still be some payers who I think by exception are excluded. Maybe you can update me on that. And second, the uninsured and what their claims are would not be reflected as well.
We will have uninsured data as well. Well, we're not uninsured, but self-insured. I thought you said uninsured, but we will have both risk and non-risk information in the September MCDB.
Right, but are you getting 100% of the insured and self-insured plans submitting data?
We should have all of the information in the MCDB. I mean, that is required to actually submit information to the Healthcare Commission.
I think they are missing small carriers. There is a threshold, isn't it? Did you remove the threshold?
Well, there's a threshold that we will have most of the information. I don't know if it's 100%, but we will have most of the information.
I had a couple of questions. I first am thinking, and I don't know if others around the table are feeling similarly, that it would help me understand this if I saw a depiction of, what the data looks like at different stages, I think. It's hard for me to discern exactly what we're talking about here. And that might not be the case for others because it's, these are, okay, the payments made, it doesn't reflect kind of, well, what the charges were. I think that's relevant, charges versus payment, and also reflecting down coding and various things like that. So well, I don't know if that's captured.
This the MCD captured bill charges and also reimbursement by the provider, by the insured to the providers, and also the total paid amount. So which would be the allowed amount plus whatever the member liability is.
And I think all of that is, such an important part, the whole equation, because we are, as I'm guessing here, we're only talking about the physician side. That's the data that you have.
We have
no? Okay, so sorry.
Institutional and
maybe if we finish, there are some explanations in the back what elements are going to be collected. Maybe once, if you go through that might help with that big picture.
Okay. I do have one question. What is the what is CMS requiring? Or does this meet CMS's monitoring requirements? The 9 months with the 9-month lag, or what did they specify they want?
CMS is actually submitting the data to us, so we're actually getting data from them faster. So we're on a 3-month lag schedule with CMS, not a 9-month lag schedule. But I think they haven't programmed the template yet, and they have to program the template. But right now they're submitting total cost of care data with a 3-month lag.
On the all-payer one, our report is due June 30th, but a lot of the measures that are in the list are not ready for the June 30th, and we are discussing with them to have something in the fall to fill whatever we cannot report in June. And if this holds September, we would rush to create those templates quickly to make the timeline for it. But our primary use, so that's the monitoring piece. The detail that we want to look at is the shift question, and for that we want more timely and on a quarterly basis trend analyses.
Okay, any other questions about the timeline for NCDB? Okay. So the reporting template will collect aggregate claims count and expenses for specified categories, and we'll review those categories in the next couple slides. So the categories of service comes from both institutional claims from the UB04 and the professional claims from the CMS 1500 form. We're also looking at geographic granularity. We're focusing on Maryland residents. So all the claims for these Maryland residents to be determined by the billing zip code. We're also looking at various demographic breaks. These age breaks that we're looking at 0 to 20, 21 to 44, 45 to 64, and 65 and over. And then we're also looking at the data by coverage group, small group, large group, fee-for-service and HMO for Medicaid and Medicare, and as well as the duals. So this is the proposed, and I know it's really, really small, aggregation for the institutional claims. So we first start with the UB04 claim, and then using NPI or CCN, we break it down into Maryland regulated hospitals, and I know it's really, really, really tiny. Maryland unregulated hospitals, and then other unregulated, and from there we further disaggregate by bill type within those 3 major buckets. And then for the inpatient and outpatient, we further break it down for the Maryland, or I'm sorry, the regulated side by rev code. So, and I do apologize for it being so tiny. Any questions on this one? Go ahead.
I think it might be helpful if we could get some kind of distribution of expected, what that's like, how much status is.
Okay. Excuse me. When you speak to SNF, I understand there are Medicare charges in SNF, so you got to collect that data. There are also Medicaid charges, and they are different. Some of those may not be a program you're monitoring. Is that correct?
Right. So this would include like the unregulated and other things that are out. Is that your question? Or
no, I think what I'm trying to get at is I think there are some Medicaid expenditures occurred within a SNF that are not part of the capitation monitoring that you're doing, whereas Medicare SNF charges and payments are very much a part of that.
Mm-hmm. So the guardrail versus the monitoring. The Medicare all-payer, all the expenditures are in that guardrail, total cost of care, that we are going to monitor compared to the national trend. We need to be under the national trend. The all-payer one is for us to look at the shifts, and also we have the annual monitoring report for the CMS, where we are going to do a total cost all-payer, and for that we are pulling Medicare, Medicaid, and private together. And SNF Medicaid is going to be in that total all-payer cost numbers.
So it's not just the health choice program, which is primarily the hospital, physician, home health, all those other costs. It's also, I mean, most of the patients in skilled nursing facilities are Medicaid, right?
Yep.
About 80%. So you're pulling all that data as well.
Medicaid is going to be pulling all that data and reporting it at the aggregate level with the detail that was in the previous slide by zip code and.
Is that part of the 3.58% cap?
No.
It's not. Okay. That's the clarity I was trying to see.
3.58 is only hospital fees.
Okay. All right.
Which is coming from our data.
There's an ongoing interest in the total cost of care from a perspective of making sure that what happens in the hospital doesn't result in a shift, but more importantly, just really focusing on the total cost of care as long-term as the area to be focused on. So for phase 2, we're focused on total cost of care. For phase 1, Medicare has the guardrails that we have to pay attention to, and we're focused on monitoring shift to make sure that we understand when shift happens. So it's hard to read, so if you kind of take a step back and look at it, what we are doing is we're looking at Maryland's regulated hospitals and then all other Maryland hospitals. So we are going to be looking at the shift between regulated hospital and unregulated hospitals, which are specialty hospitals mostly. And then the other unregulated one is all other non-hospital institutions in this slide. So SNFs, home health, everything is on that bucket. And then we have that further breakdown for the hospital regulated side because looking at the rehab, oncology side, those are the services that we think could have some shifts that we would like to look in more detail. And similarly, on the outpatient side, again, we are looking at the ED, and you're going to see urgent care is on the professional side, surgery, rehabilitation, and also the clinic and side. So we try to do more detail on the hospital side so that we can trace those trends with the ambulatory services on the other side.
And what is the source of the professional claims?
It's the CMS 1500.
So Medicare is providing that?
Medicare is providing it. Medicaid is providing their professional service data, and then we would get the other data from the APCD. But it's based off of the CMS 1500 form.
But a lot of Medicaid data is going to be with managed care plans.
Right. So they are collecting the data from the MCOs and then submitting it to us in an aggregated form.
Okay. That's often, I mean, I don't know what it's like in Maryland, but in a lot of places, Medicaid MCO encounter data isn't always fabulously clean.
So there is, I think there are other experts in the room can talk about, but Medicaid has been collecting aggregate level information from MCOs for a long time for their rate setting purposes. And we work with them to modify that aggregate reporting to detail it a little bit more so they can map to what we think is appropriate for calculating this shift. So that reporting is, I think they have unaudited one and then they audit it, so it's kind of a clean and good data for the MCO population. It's not at the claim level. It's going to be aggregate level.
Got it.
It might be a little cleaner since it's being used for rate setting than it otherwise would be in states where they're not using it for rate setting.
Okay, that's great. Thank you.
And they are going to do similar reporting using their fee-for-service claims. And I think in the long term, the plan is for Medicaid to send their claim level information to MHCC and have the current MCDB to become more all-payer, all-claims database.
Is there a time frame on that?
Time frame for adding Medicaid? Yeah, claims. I would defer to MHCC on that.
I will have to, I'm not sure the timeline for the Medicaid claims, but I could actually get back to you on that.
That'd be interesting to know.
Is the national data going to be consistent and consistently accurate? I heard a little bit of a, well, the national data might not be as clean as the data here because we're using it for rate setting. So is that going to cause any distortion in the?
We're not benchmarking national Medicaid.
But in total.
For total cost of care, that's not one of our guardrails.
Okay.
I can tell you for sure that national Medicaid data is not consistent, even more because of the coverage issues, because there's different coverages, different categories of enrollees and different coverages across different states, and the waivers are different, and it's really an interesting benchmarking effort, and there are a lot of items that are capitated inside of Medicaid, so when you get into claims data, unless you actually have a capitation reconciliation for MCOs, it's fun.
The total cost of care is just Medicare? Okay.
For the guardrail.
Right. So on an all-payer basis, the total cost of care is primarily for monitoring in Maryland the potential shift between the services moving from the hospital to the non-hospital setting. The only question I would have is, you're only getting this data, or maybe I should ask this, are you getting this data just for Maryland residents who are only using Maryland providers in this database, or if a Maryland resident uses services in D.C. or Virginia, Pennsylvania, would that also be picked up in the data that hospitals and other providers are submitting to the MCDB?
Well, we have in the MCDB both Maryland and non-Maryland information. So, however, the HSCRC want to actually get the information, it's available for that purpose.
Because what I was getting at there is the shift could be from hospitals in Maryland to hospitals outside of Maryland, just as much as it is from hospitals to non-hospital settings. So you will have Maryland residents' use of out of at least of the surrounding states.
Mm-hmm. So it's in the
on an all-payer basis.
So it's in the other unregulated, and the first one there is the non-Maryland hospital inpatient and outpatient. So we are looking at Maryland residents, but then services provided anywhere, and that's on our other unregulated space.
Thank you.
The database from the carriers includes data from out of state for Maryland residents.
We do have non-Maryland.
So CareFirst submits claims for services in D.C. into this database, for example. That's my long-term understanding.
Well, I'm pleased to hear that, because I actually just came from a national meeting where in these all-payer claims databases, many of the Blues plans have not been submitting their data to these databases. So I wanted to make sure this was the exception here, which is I'm glad to hear.
So I'm not sure if they are enrolled in the national plan, whether they will make the threshold to submit that information, but for the local plans, and if they are still meeting the thresholds, all their claims should be in the database.
So I think that was going to be my question. Do we think we have all the payers, or are we missing some payers? I mean, obviously CareFirst is a big payer, and I assume we got that one. Are there any others that we're missing commercially? Anybody know? I'm assuming when we say this that we have all the universe, and that could be a challenge. I suspect we don't, especially that somebody who's got insurance from some company out of Omaha or something.
Right. We should have all of the payers who are actually doing business in Maryland.
And they're required to report, or is it voluntary?
They are required to report.
Okay.
What about the self-insured, self-administered claims?
We have that as well, yes.
And the TPAs submit those?
Yeah, I mean, the TPAs, we have for the first time for 2013, and PBMs as well.
Okay, so I'm confused then. If they're required to, if all the payers are required to report to MHCC, then what does the term voluntary mean? That was
So again,
voluntary was
for
something
aggregate.
special for us because we're concerned about timeliness, and also, for example, if the payers are interested in shift, for example, for us, if HSCRC, if we were just first getting the data 9 months behind, then we're really a year and a half behind being able to use that data to address shift. Now, data is coming into MHCC on a quarterly basis, but it doesn't have all the bells and whistles very fast. So the question is, you know, do some of the commercial payers want to help monitor on an aggregate basis, on a geographic specific basis, what's going on with ambulatory surgery or oncology or whatever, to see if there are apparent shifts to non-regulated settings to help us with our monitoring. Right, and they wrote a white paper saying that they should do that, and so we developed the template, but the template's useful for multiple purposes. One, it's useful for voluntary, but it's also useful for us to aggregate the all-payer claims database or the Medicare database or the Medicaid data that's being submitted. So regardless of whether we have voluntary submissions, the template process is useful because it kind of describes how we want to aggregate the data.
So one more question on the, to what extent is Medicare Advantage an issue in Maryland? And how, if it is an issue, how is it being addressed by Medicare?
So the question is, how is the total cost of care being collected for Medicare Advantage?
And Medicare, right, because I presume it's not just Medicare fee-for-service, the guardrail, or just the guardrail?
The guardrail is just Medicare fee-for-service. So I don't know whether MHCC is collecting anything on Medicare Advantage or not.
There's not much penetration in
not
Maryland,
much.
right?
I believe they don't, but don't.
I'm not sure. I have to check.
But we have one of the Medicare Advantage plans, Cigna, is very, very interested in reporting it at the aggregate form and helping us. He actually helped us develop this template also. So we would have some Medicare Advantage aggregate level report, which we can combine with whatever source we end up using for the reporting.
Can I go back to my earlier questions? I don't know, because we're talking about just the overall issue here. This does have to do with the professional claims again, but I'm again struggling with getting the biggest, clearest picture. And do we know the denials, the downcoding, and for the professional claims, all the uninsured, uncompensated care? So is that I can't imagine how you can be getting all the uncompensated care, but I just wonder how much you're able to see from what you get.
I think MHCC has been more focused on the issues of professional practice related to claims, and so we're not. So, for example, they've studied if something's in par participating or non-participating, and that's something that MHC has been doing now for more than a decade. And so we're not stepping into that because they're doing it. And so that's not really something that we'll focus on. That will be something that would still be in the purview of MHCC because we don't really regulate doctors at all. So what we're focused on really is looking at how costs are developing and whether there's shifting between hospitals and non-hospital settings. So I don't think we're not as focused on those issues at HSCRC. We're not saying they're not important. It's just not our focus of what we're trying to do, and it is MHCC's focus.
And I understand that, and I guess maybe I'm getting too fixated, but when we talk about total cost of care, then in my mind, we want to see that valued as globally as possible. So maybe it's a discussion for another time and with the Healthcare Commission, but I think it's just something important.
Just in terms of looking at the uncompensated care. And I know that MHCC has looked at the uncompensated care in the past.
And getting your hands around, you know, whatever, and I don't know on the rate setting side so much, getting your arms around the down coding.
What about the up coding, Barbara?
Well, I know you're looking at that.
No, we're not looking at that on the physician side.
Well, that
but,
needs to be looked at too, of course. Yes.
Because I think you'll see a lot more of that than the other way around.
Well, we need to look at both.
I was wondering if you could clarify aggregate data, because at some point you can aggregate to the point where it doesn't become useful. And so, and what are you losing in your aggregation?
So if you look at the granularity slide 6, we wanted to have this aggregate at the zip code level and at the age breakdown and at the coverage. So for each zip code, we want to have a separate age breakdown and also the coverage group so that you can do the trending appropriately. Yes, it is still not a single sheet of paper where you have the buckets and the totals. It's going to be a database, but it's going to be not millions of claims, hopefully, you know, in the thousands of rows where you can do much more quick analyses of looking at the primary service area based on the zip codes and then have all those buckets aligned for trend analysis.
There's enough detail you can do your job.
We hope so.
Yeah, I just actually on that granularity had one quick comment on the age breaks.
Mm-hmm.
I would try to make that consistent with the age breaks we're using in our demographic adjustment. I sort of, you know, I know you don't want to get too complex on this, but I'm particularly concerned about that 0 to 20 group. We had discussions in the demographic subgroup that particularly the 0 to 1, the newborns, you know, have a different cost trend than those who are in the, you know, 1 to 15 and up. So if you just maybe take a look at that when you start producing some of this information.
The one good thing about that group, the 0 to 20 in terms of shift, is they really don't use very much hospital service at all once they are born. So there's really not any outpatient surgery or lab tests or hardly anything going on in the hospital that we're worried about from a regulatory standpoint, leaving the campus, maybe a little bit in clinics. But
which is why I suggested breaking out that close to newborn 0 to 1 population from the 0 to 20.
So I would say, you know, when we look at the actual claims, obviously we have much more flexibility in looking at different breakdowns in different areas. We wanted to align this with the Medicaid total cost report, so that's kind of the age breakdown that they are using. At least when they send it, it is aligned with our regular reporting. It was, I think, a challenge. Like then you get into very detailed numbers, and there is an issue with the confidentiality at the zip code age level. So there was also another push to make it more aggregate. But certainly once we have the claims on the private and the Medicare claims, we could do even much more detail than that.
All right, so quickly I'll go over the professional breakouts that we're thinking about. So we would start with the CMS 1500 form, and then break out the primary care, ambulatory surgery centers, urgent care, the freestanding labs and radiology, pharmacy, and other by NPI, and then make further breakdowns based on payer specific. So Medicaid has a certain way that they're grouping the hospice and the home health, and Medicare has a certain way they group some other things. So we're based on those groupings, and as long as they're consistent over time, we should still be able to look at those trends.
And this says retail pharmacy, but is that actually physician-administered drugs?
No, that's just like CVS, Rite Aid. So right. So the physician-administered drugs would go in the either primary care or specialty.
Funny. So I'm just wondering why Medicaid, hospice, and home health are in professional claims when other hospice and home health are in institutional.
So they break, from my understanding of the way Medicaid is, they break out their professional portion of the home health in a separate bucket than the institutional. So on the institutional side, they'll have those institutional charges, but for Medicaid only, they're breaking separately.
So these are just the professional home health Medicaid charges,
Right.
and the rest of the institutional Medicaid
Right.
would be in the institutional.
Right, for like Medicare and
My understanding was that the different types of institutions like hospitals would have a subsidiary, which is a home health, and those would bill on a UB92, and freestanding home health agencies would bill on a 1500. So it's not really a professional services distinction. It's more the organization
of where they're billing.
Of type of, it splits in Medicare too. It's a mess. But it's which billing claim form they use, and if it's associated with the hospital, they use the UB90 or the UB form.
How are you picking up the retail pharmacy data? Did you say you're getting it from the chains, or is there another method you're using?
I think it's just visits. If this is on the 1500, we're just talking about the visits in the retail pharmacy, not the drugs. So this is just when somebody gets a vaccine or they get a service, so it's going to be a tiny little thing. I think it's going to be tiny, bigger than it was 10 years ago, but still tiny. This is vaccinations.
Outside Target,
Minute
CVS.
Clinic. Yeah. Minute Clinic, vaccinations, things that get an E&M code that would come in on the 1500, not something that would be coming in on a PBM and having an NDC, but something coming in on a 1500 with a CPT.
So Donna, where do the pharmacy costs get into the total cost of care? They completely out of this, except for the hospital stuff. That's obviously in the hospital activity. It's not in the claims data if it's a covered service? I guess not?
A physician-administered drug is in the claims data.
No, I'm not talking about the physician-administered stuff. I'm talking about the folks who have insurance coverage, and their insurance program covers their pharmaceutical costs. They walk into a Rite Aid, and they walk out with a $100 prescription paid for by
Medicare can't give us that data. The MHCC has had difficulties in collecting it because, for example, Care First might do the medical side for the state employees of Maryland, but PBMX does the drug claims for Maryland, and Care First doesn't have the pharmacy claims for the state of Maryland. So the pharmacy claims really haven't been reliably and routinely included in total cost of care databases.
But aren't they a source of one of the most expensive parts of the model, the care model growing over time?
Right now they are.
It is.
The growth in pharmacy right now is around 14%.
Yeah.
So
we won't have that in this, which it is what it is. I just wanted to make sure I knew what was not in there.
there are some ways to get pharmacy data, but it's not going to be in our total cost of care. For example, for Medicare, for retirees, some of the employers pay the pharmacy, so there's actually not a full data set that has the total cost of care with drugs in it because Medicare doesn't even have it. They don't even have the total cost of care for their enrollees because employers are paying some of it and they give them a supplement. So it's not even really available.
Right.
It's not available.
The solution for all of us is to use drugs to solve all the problems. Really hard.
But the drug cost could be a real opportunity for savings. If you can drive generic utilization of drugs, you can really drive down the cost. It's unfortunate that it's not going to be there.
I think MHCC has some works going on to get the data from
We have
PBM, right?
we have PBMs going to be submitting drug information for the self-insured plan.
In terms of taking risk, I'm breathing easy because we don't have drugs on the list when the costs are growing at 14% a year right now. So it's on my grateful list as opposed to my non-grateful list at the moment. Yeah, so right now we're going in the wrong direction with cost on that. So I can see that everybody's really resisting talking about market share, so we're not moving through our list very quickly. So are we finished with that topic? I think several meetings ago, and we presented a document talking about a process to relieve global budget corridors. Right now, the contracts have a 10%, 5 and a 10% corridor, and when a hospital reaches when their volumes have declined by 10%, they don't have an automatic avenue to charge above their approved rates that would allow them to collect their approved global budget. So since we really want people to invest in reducing avoidable volumes, we wanted to provide an avenue for corridor relief. But at the same time, we wanted to review the cause of the volume decline to make sure that consumers were getting the services that they should be expecting to get, and that the reason for the volume decline wasn't a loss of market share or a shift to an unregulated setting before we were relieving the corridor. Hopefully, over time, as we get more of these other data sets in, we'll be able to think about this in a more expedited way, but for the time being, we are focused on doing a review to grant corridor relief. So we laid that out in this white paper, and we presented this to the Commission, and we also took comments from the payment work group, and we incorporated them back into this document. Some of those, for example, were granting corridor relief during review, et cetera, and so forth. So, so we've reflected the comments in here, and we just wanted to see if there were additional comments as we're actually starting to conduct some reviews. So we wanted to see if there were additional comments at this time.
Microphone.
I was saying, what happens between 5 and 10%? Is that just a notification, or is that an application, or not an application?
It's a permission from Ellen, and Ellen will want to know what you're doing that's causing your volumes to go down, just to make sure that we're kind of checking the boxes and making sure that your volumes are going down for a good reason. But it's a fairly routine grant. So it's not gonna cause an in-depth review, but there is a notice requirement, and Ellen is focused on granting permission.
So it's an easy process of 5 through 10, and a more difficult process of 10 and above, obviously.
Correct. More evaluation once you hit 10. The GBR contract doesn't outline a relief process, and so we've outlined one here. So because we don't want people to stop reducing avoidable utilization, we want them to invest in good community-based care to relieve hospital use. But we want to make sure that we're not granting relief for something that's been shifted somewhere else.
Donna, I think there's a statement, page 2. Consumer representatives have expressed concern about increasing unit rates when volumes are reduced. So I think some of what drove this policy is that particular concern. And price is only one component of the total cost of care. I mean, take the last 50 minutes of discussion was about total cost of care. And so from a payer's perspective, it's PMPM. With the total, with the Medicare waiver test, it is the per capita cost. So I would just like to evidence on the record that price and unit price is only a component, and that if volumes are driven down significantly, that will drive up the unit price conceivably in a global budget scenario. So and as I understand, as we've had several discussions, to be clear, when you're looking at a 10% corridor, it's on the total global budget of the institution in outpatient observation, admission, ICU, whatever, and not just a particular unit of service.
Correct.
Thank you.
So basically, the corridor says your volumes can fall by 10%, and that could be in one center, but you have the flexibility to raise prices in every center to recover up to a 10% volume decline, so that you can maintain your global budget without permission. And above that, there needs to be a review.
So it would be important, as each rate setting is done, order 9-SI is cut, that there be some rate realignment that may reflect the changes in volume within the settings. I understand you're using FY13 to do this year's rates, but there may have to be some rate realignment to recognize that there may have been some shifts that were generated in the care rendered in the prior year.
Rate realignment is against 2013 annual filing, so a rate is a rate, and it, from a mechanical process, the volumes that are attached to it don't matter when you're trying to generate a global budget. What matters is the volumes that you're projecting to have times the rates that you have from the rate order, and that's what drives your revenue budget. So your expected volumes times your rates, and then whatever you have to do to those rates to get to your global budget, increase or decrease them based on your actual volumes.
Donna, but just so I want to make sure I understand it correctly, you're not talking about rebasing the volumes each year, correct? So if a hospital did a good job of controlling utilization and, PVCs and the readmissions and dropped their utilization 8%, you're still using 13 volumes to develop a rate. So they would have to overcharge 8% initially to even gain that back, right?
Yes.
So at that point, if that would happen, then they would only have like a 2% corridor to improve efficiency.
Are we talking about
an 8% volume decline is a tremendous.
It's huge. I understand.
It's huge.
I'm
huge. So, it's a lot. It's a huge volume decline, and we want to find out why it happened before we give relief. But once we find out why it happened, then we're going to grant relief. And once we grant relief, then we can update the volumes in the calculation so that we're not going off of
question. When are we going to rebase volumes? At some point, you're going to be rebase volumes, correct?
Yes.
You're not going to do it annually, but you're going to do it at some point?
Yes.
Do we know when that, like you're doing it every 2 years or 3 years?
I don't know.
Okay.
I don't know yet, but we'll be talking about it. We've talked about some ways. Already we've outlined ways to rebase volumes but still keep the corridors until they're released. So there are mechanical ways to rebase the volumes without removing the corridors. Okay. So it's a complicated calculation, a little bit complicated, and if we need to do that, we'll do that too.
So if a hospital did the extraordinary and reduced its volumes by 8, 9, or 10%, and has programs that it expects would drive volume down in the current year by more than 2 or 3 or 1% accordingly, they should be in front of the commission staff explaining that now.
Yes.
Yes.
Yes. So if you've already have if your volumes are down 7% from 2013 volumes or 8% from 2013 volumes that was used in your base period, then you should come to talk to us.
I'm just curious, if we're using the word
overall
volume, what are we actually considering volume? Is it on a rate unit basis? Is like
units times rate?
So you could be out of whack in your outpatient surgery department regulated by 10% or more, and that would trigger coming and talking to you all?
That's one center. So right now we're talking about, there are rate compliance requirements on a center basis, but right now we're talking about the overall global budget. So if your overall global budget is $100 million, if you've knocked out 10% of the volume, so that if you took your rate order, you would only come up with a $90 million revenue. You're allowed a 10% quarter, so you can charge $100 million at that point. But once you get down below a total aggregate volume decline of 10%, you need to have a review.
Okay.
So release the corridor.
We're keeping rate set at the original rate order and then seeing what our volume changes to, and that aggregates, if it's in aggregate 10% differential, then come talk.
Then you're going to have a problem charging up to your global budget. So you'll need corridor relief. So 10% volume drop is a lot.
Oh,
I mean, it's big. I'm not. And several of the hospitals are getting close to that level, especially some of the TPR hospitals who have experience and have now invested in programs. Several of them are looking at that corridor. They haven't hit it yet, but they're saying, wow, this could be tight. We have plans that may take our volumes down 15+% over the next 2 years, and we want to get some corridor relief in place. So we're actually starting to review all the TPR hospitals now because they've been into the program longer. But others who think they want a quicker review because they think they're already bumping a corridor should come in at the same time, and let's get you done.
I wasn't really looking. I was just trying to find the definition in the write-up somewhere so that. It's not explained without you.
So we could explain it better. We could explain it better in the document.
We talk volume, but it's not saying that you're calculating it based on the rate order times your existing volume compared to the rate order times planned volume, and that differential is the key of the trigger. So I'm understanding the question.
Just think of it as you can't charge more than 5% above your approved rates without calling Ellen, or 10% without an application
or a review.
And Donna, the purpose of this mechanism, as I understand it, is to sort of squeeze out unnecessary utilization in the system. So if a hospital,
it's not just that; it's also to provide better care.
Right. Mm-hmm. So if a hospital is doing that, then they're doing what they're supposed to be doing. And what is the mechanism for assuring that, I use this word loosely, windfall, gets applied constructively? I guess that's the way to put it. I assume when you're reviewing a request for relief, then that is a question that you're going to be asking, and what are the guidelines for making that determination?
So I think there is a list of things that we're looking for in here on page 5 of things that we would be looking for in terms of evidence that the reduction is based on activities that are being conducted by the hospital. So that's what we had laid out here. So getting information from the hospital, we are going to be getting information from the hospital about their programs. That's part of a filing that the hospitals will be doing to describe their investments in population health. So that we have a work group that's working on that now. And then providing an explanation of volume decline. So here's a volume decline in OR. What did you do to get that volume decline? And what happened to that volume? And we're working on market share analysis. So we should soon be able to supplement data that we get from the hospital with a market share analysis that the commission's doing, and we're doing that in our review processes now. For example, some of the TPR hospitals are putting pretty high investments in some of their approaches to reduce utilization. I was at a meeting yesterday, so Western Maryland Health System is putting in a SNAP program, and then that has to do with reducing nursing home admissions. So it has a pretty high investment point. Some of the disease management clinics have a high investment point, and they're not all being charged for. They're being operated as disease management programs without charging. So those are some of the things that we have to try to understand when we go through the review process. So when we look at the volumes, we can see what went down and have the conversation about what caused it to go down. And if it's not a utilization intervention program, then we'll be less likely to provide relief for it.
So Donna?
Yes.
Is Mike Curran. So again, it might be helpful if at the bottom of the page 4, if maybe you can just add a couple more lines that recognize the fact that many of our organizations are making additional investments around IT technology, decision support technology, ambulatory facilities, physicians, and they will be taken into consideration as a part of that overall assessment.
Okay, we'll be glad to do that, Mike. Camille Bash would like to ask a question or make a comment.
You would need to use the microphone with the green light.
I had 2 questions in this area. One is this discussion that happened a minute ago. This gentleman, I don't know his name, he used the expression FY13, and then Michelle started asking a question. Staying within the 10% quarter, staying within the current rate order you have, not 13, 14. It's the current rate order. At least that's how we're approaching it, just like we used to do before. He just gave the example of 13. I just want to make sure we all know.
The rate order volumes are based on 13 with a few adjustments.
But it's staying within your current rate order.
Yes.
Okay. And then secondly, on that page, did you want to say something before we go?
Well, yeah, my point was, though, that if a hospital, in order for them, we support the hospital should be able to realize their full GBR. And in order to do that, if your rates are then artificially low because of your volumes are not attainable, then you have to overcharge from the beginning. And, you know, that's what's going to happen. So it was just a point.
You have to charge above the rates in the rate order, but it's not an overcharge because it's the approved revenue is really what your approved revenue is based on your global budget. But you're not allowed to charge more than 10% in the aggregate above your rate order rates.
And then on page 5, again, I haven't read this whole document, so I may be missing it, but some of the points here, for instance, on number 2, when you look at the market share documentation, we're talking about certain categories of revenue. So we would be carving out certain things. So I just want a clarification when you finally resolve this review section. And I'm going to jump to number 3. We might have had a reduction in our CMI because we got rid of MHACs. And MHACs might have been a reason why we had a higher CMI. So I just want to understand when we're looking at this and when somebody writes a report to you, are we carving out the bad things in each of these different categories, or are we leaving all the stuff together and saying we had a 10% decline of admissions, and then in number 4A, is that where we show, oh, and by the way, in that decline of 10%, 8% were because of readmissions? Or are we showing in number 1, 2, and 3 without the PAUs?
Well, I think you'll see once we get to the market share analysis that we are looking at fairly granular data that separates out PAU and readmissions in the data. So we're trying to focus on looking at market share in a granular way. So we are focused on, for example, if your OR volumes go down, to understand what happened to the cases. Did they go to another hospital, or did you lose a doctor retired and you didn't replace him? If the doctor retired and you didn't replace him, we might not really want to give you rate relief for that. If you didn't do the service, we don't want to necessarily give you rate relief for a service you didn't provide.
But if we retired a physician who was the majority of our MAUs, MHACs, if we retired a physician as the majority of our MHACs and our denials, maybe you would.
Yeah, we might.
Okay.
So Donna, could you, it's good to hear that the Commission is going to take into account these significant investments being made off campus to avoid hospital utilization. That's good, and I thought you were heading in that direction. But could you imagine a time where just because the resulting, it may be defensible, but the resulting rate is so high you have to block it for that reason?
Yes.
Which brings me to this point. I thought you would say that. So we start, because I think it would be a mistake to block the right thing to do because that unit rate is too high. Could we ever imagine, I'm going to get some stones thrown at me in a minute, a world where there are sources of reimbursement to hospital that's not through the patient bill, but directly from the payers, so that the hospital can continue doing the right thing that benefits the payers, but not have a price that gets to be out of whack. Because my concern is hospitals will start bumping up. Eventually, I hope we get here as an industry, we have that problem. The market rates then would be high for everybody, but could you, maybe you don't want to answer this, but at some point, we don't want to throw the baby out with the bathwater.
Right. So I think in areas where there are multiple providers and replacements, then some capacity gets removed from the system because we don't replace unused capacity, and so that helps to keep the cost down. And in places where there are multiple facilities and we have excess capacity, we may want to try to reduce the capacity in the system to help drive fixed costs out so that we can keep the cost in place. But so we haven't defined what an efficiency outlier is yet, but we need to come up with some measurement of that. But we're not thinking it's. We're thinking it's definitely something north of 10%. I don't know whether it's north of 20%, but and I think in the urban areas, the market will dictate somewhat what the efficiency outlier is, because there's the potential for channeling if people's rates get too high. So that, the market may drive that.
See a signal that slow down what you're doing, because you may lose 100% of the money.
We're not going to have that signal. We're trying to signal as hard as we can in the other direction. We will grant relief for people who are reducing PAL. So that you can quote us on that. We will grant corridor relief for people who are reducing PALs and investing.
Asking you for that 20% increase.
I didn't say it. Oh, no increase. No increase, sir. Maintenance.
This is David Johnson. May I ask a question from the phone?
Yes.
So from an employer perspective, I want to make sure I understand how much could payment for the same procedure vary at a given hospital based on the hospital doing well on reducing cost in the aggregate?
Right now,
so for an individual employer, let's say they, yeah.
Right now, on an overall basis, we have a corridor of 10%. So right now, that's what it is, and so we're focused. That's an overall basis. So I don't know if I'm exactly answering your question, but on an overall basis, it's 10%. But we will grant relief if we're presented with a case where hospitals are having higher volume decreases and for the appropriate reasons and making investments to improve care. So if we have somebody making investments to improve diabetes care and that's not showing up as a volume somewhere, for example, then we'll look at creating some corridor relief.
But Donna, isn't it true that in order for that 10% to happen, volumes are dropping? And assuming that it's spreading across all the payers in some proportionate way, the total cost should be not going up.
The total cost shouldn't be going up PMPM, but what he asked was the procedure cost. So
right.
The procedure cost or the visit cost could go up, but the number of volumes are going down.
Right. So the employers and the insurance plans should see costs in a stable environment and unit prices going up.
Right. So, for example, the overall per capita limit of the new waiver is 3.58%. So that is on top of all of this. It's not going to go north of that.
Right. So I think we need to keep flipping back to that, because I think we're getting a little bit too much in the unit cost. And I know where you're going, and I agree with it, by the way. But total costs for the health insurance plans in the state shouldn't be going up, even though the unit prices might go up, because the volumes are going to drop. You're paying for less volume.
And the reason I'm asking about an individual is I'm thinking from the employer. Let's say it's a 500 employee company that only has 3 of these procedures a year within its population. That single employer might see its costs go up dramatically from last year for those 3 procedures.
Dave,
I'm not arguing against that. I'm just trying to understand the magnitude.
No, Dave, I would say you're correct. I think the folks that I represent would also argue that given the increase in high deductible health plans, the out-of-pocket cost to that enrollee in this environment would also be going up significantly, and we're likely to see significant increases in bad debts and other write-offs in our hospitals because of the nature of what we're doing, that we're doing the right thing by reducing unnecessary care, but within the global budgets, the unit price going up and what the individual on a unit or service-by-service basis pays out of pocket is going up.
And I would also point out, just from the employer side and the patient side in Maryland, that the prices in Maryland that patients and employers are paying on average are less, or 20% or more less than surrounding states. So it's not, we're going into this, we're definitely going into this with a lower price points for the commercial payers in Maryland than surrounding states. So we're going to control utilization, and prices will go up in the course of controlling utilization.
But also, this is Ann Meck, to make a comment. Wouldn't you expect some of the patients, the consumers, the employers, and the health plans to begin to do some price shopping and try and direct their enrollees to hospitals where the unit price per procedure is lower? And maybe then market forces would come into play, and there would be less incentive to raise that unit price or request rate relief?
But to that question, I think the difficult thing for the employer would be predicting. If the employer doesn't know from month to month how the hospital rate, unit rate may change, that would make it very difficult for the employer to steer people.
Would the payers be able to?
Right, because the rate could change.
I don't know, would the payers be able to get a handle on that?
I think.
Is there any way to predict which hospitals' rates are likely to go up within that 10% by virtue of how much their volumes are dropping on an ongoing basis? Or is this just something that's going to come at everybody out of the blue, out to the people who pay the bill out of the blue?
You know, I guess I'm looking at what some of the commercial rates are going up in other states, and you know, we've been focusing on looking into it, and the rates are going up well above the 3.58% that we've been focused on as a limit in Maryland, and we did not even grant that amount of a rate increase in Maryland. So I guess you know, we have to stay. We signed up for a waiver that's an aggregate cost waiver, and we're focused on managing the aggregate cost. We will focus on excess capacity at some level, and there may be some. There are and will be some plans that focus on where they send their patients. There are already, there have been, there will continue to be.
Okay. And this rate adjustment phenomenon is nothing new. This has been, it's been going on under the charge per case. Hospitals are managing their rates up and down under the old charge per case system. It's just a large, now we have a larger pool. And so, yeah, it would be slightly larger. I would also say that before Jerry changed the uncompensated care policy to a full sharing across the state, you saw a greater variation in rates in some hospitals because of the uncompensated care provision, and we didn't see necessarily people flocking toward, you know, toward hospitals that had lower rates at that point. Am I correct, Jerry?
And you know, I would also say with the economy improving, that our number one concern hasn't been whether there's going to be 20% volume declines. It's really about making sure that there's some balance of declines with increases that come from an improving economy. But we'll see. You know, we're at a point where we'll soon see what happens with volumes.
Hey, Donna.
Yes.
It's Mike Curran again. someone mentioned earlier, we do have to keep an eye on the total cost of care, because everyone is focusing on a single occurrence. But so hypothetically, last year we had a patient and they were admitted twice and it was $5,000 a case, so we would have paid $10,000. If we're able to make investments around technology, devices, medical manager, say it costs us $1,000 a year, and then we end up with just one admission, even if we get paid $7,000, your costs for 1 year actually drop from 10 to 8. That's a good deal. Even though you may be looking at the price of the admission and say, why did it go up $2,000? So again, the earlier comments about total cost of care have to be considered, and it can't just be an episodic event that we get priced at.
Right. So I think basically what you're pointing out is maybe we could add some language to the coroner's paper that really get into the total cost of care and pointing out the value that comes from focusing on reducing readmissions and reducing admissions for ambulatory sensitive conditions, et cetera, and how that really is a benefit, so that if the employer had 3 cases last year, maybe they're only going to have 2 cases this year, so they're still going to be net plus.
Correct. Thank you.
I would think we're still over into the market share discussion as well. So one hospital reducing CAL and others in their market not reducing it. Traditional style of calculating that would not give that credit. So when we get to that,
it'll be in the discussion for sure. So basically, we have comments that indicate that we should add a little bit more relative to the total cost of care and talk about the investments that need to be made to reduce avoidable utilization and improve care in the context of the document. We already have comments about consumer concerns about price, and we heard a little bit about that again, but and making sure that they're getting the services that they bargain for. Are there any more comments before we go on to an update on transfers?
All right. I don't know if you wanted to skip transfers or the market policy. We'll see. So you have the document updated from the last meeting that we had, and I prepared a summary PowerPoint to kind of have you look at it in a more simplified and a high-level way. So as you remember, we've been working on the transfer policy since the summer. We had several meetings with the subgroup on the transfers to identify the measurement issues, and we had the August meeting that we discussed as a work group, the general policy. In general, the focus of the transfers, if you remember, is really ensuring the access of care for the complex cases to the academic medical centers. So we're looking at the transfers from community hospitals to the 2 academic centers in the state, University of Maryland Medical Center and the Johns Hopkins University. The source of transfer, traditionally we've been looking at inpatient to inpatient transfers, but we are including also the transfers from the emergency departments to the AMC. So the only condition here is that the transfer case is going to be admitted at the AMC. So if they are not admitted and discharged from the ED in the university hospitals, that's not going to be part of the policy. So they can come from inpatient, they can come from ED, and then admitted to the AMC. And we discussed several exclusions, and this is based on how the global budgets are constructed in a sense. Categorical cases are excluded, from this policy because they have separate trending in the AMC budgets. Out-of-state patients are excluded, and MDC-5, psychiatric DRGs and rehabilitation DRGs are excluded because those are the cases where alternatives are available. So they are not the high complex cases that we are trying to focus on. So then the way the policy works, one of the principles was not to make adjustments for any changes, to give the stability to the global budgets and really focus on the changes that are above certain thresholds. So we are looking at the base year transfer cases, and then with some thresholds, really making the adjustments for the global budgets of ascending hospitals if they are above certain thresholds. And I tried to simplify, let's see how I did it. So I created 3 hospitals, and in the base year, they have, 2 of them have $100 transfer cases. And in the performance year, one has $120, the other one has $110, and the hospital C had $50 transfer cases, and now in the current year, they have 56. So those are the 3 hospitals. And in terms of percentages, hospital A, 20% increase in cost, and we are assuming here they had at least 10 additional cases in transfers. Hospital B had 10% increase with, again, at least 10 additional cases. And hospital C had 12% increase in cost, but they had only 6 additional cases. So we have, yep. Cost. And I'm going to explain the cost, yep, in the next slide. Then if the statewide transfer cost has increased less than or equal to 5%, so there is not much statewide change in the transfer rate, then our threshold is 10%. For hospital A, the adjustment is the difference between their actual 20% minus our threshold. So there's only $10 adjustment. So they are keeping that 10% in the revenue. If you do the math for hospital B, then there is no adjustment for hospital B because statewide we don't have a lot of increase in transfers, and hospital B is under threshold. Hospital C doesn't get an adjustment because even though percentages are high, their base is very small, so that's a volatility in the small number issue for hospital C. If we statewide observe a lot of transfers, so our cost is increasing more than 5%, then our threshold is not 10% but 5%. So then the adjustment for A is $15. Now for hospital B, they are also above the threshold, so they get 5% reduction, $5 reduction. And hospital C, they don't meet the minimum case requirement, so they don't get any adjustment. Let me stop here and see if, no, I can talk to you after as well if you want more details. And the question of how we are calculating the cost is we are looking at the transfer in cases at Hopkins and University and looking at the average charge in these 2 hospitals for these transfers. And if you remember, we had discussed in August whether we should have one price from transfers coming from ED and one price from transfers coming from inpatient. So we have 2 prices. It's the same for both the AMCs and for community hospitals, a single price. And with the base year, we are updating it with price update and also the 50% variable cost factor. So there's going to be a single price for a given year, and we're going to update it annually. Well, single price for inpatient, so 2 prices.
So is it possible for the hospital that is sending the patients to have a greater reduction in charges than their actual charge would be for those cases otherwise? Because you're using Hopkins and University's charge.
Right.
So is there a scenario where somebody's getting more money taken away from them than their actual rate structure, than 100% of their rate structure for that equivalent patient?
Could be.
Is that a problem?
At the aggregate, on the average, it shouldn't be, but rather than doing the actual cost of those transfer cases, which will put the sending hospital at a greater risk, if we were to just use whatever the actual cost of a transfer, we have cases which will cost, quite a bit.
Are there cases when the reimbursement for Hopkins and UMS is more than double the reimbursement from the sending hospitals? That's really what I'm asking, because then you'd be taking away more than they.
If the sending hospital is sending low-intensity cases over to Hopkins and University, then it's quite possible that that could be the case. If they're sending high-intensity cases, it gets to be less likely because it's an average. So if you're sending something that's high-intensity,
right? Okay.
But if you're sending a low-intensity case over and it's increasing by more than 10%, then
I'm just thinking it through.
How can I say that I don't care if you have to pay up if you're sending low-intensity cases over to Hopkins and University? Pay up. You shouldn't be sending low-intensity cases over to Hopkins and University. And there's other places that can take care of low-intensity cases if you don't have the resources. If you're missing a surgeon, an orthopedic surgeon for hip replacement, you don't have to send them over to Hopkins and University if it's not, if it's plain vanilla.
Okay.
If you send them anywhere else, it's not included in the transfer policy, in the market share adjustment policy. So low intensity is not a great deal for large increase, low intensity cases. Transferred out, not a good idea. If you're transferring high intensity cases, it's not, we just don't see that it's going to end up causing a hiccup here with some corridors, or that it would be at an unreasonable cost if there was some payment made or some reduction. Why? It's the increase.
Right. I know there's a 10 and 5% threshold depending on what the state's doing. There needs to be some education there, obviously, because if you're close by Hopkins and you've got a shortage of a physician, you don't want to send them, like you said, a 0.8 case mixed patient because you might end up having quite a bit of revenue taken away from you.
In the back of the write-up, it gives you a sense of the types of cases that are being transferred to those academic medical centers by DRG in the back of the write-up.
Yeah, I was just thinking of a situation, take a hospital that's close to one of the academics. If they have some sort of shortage of coverage, sending patients away could be, sending patients to the closest facility could be difficult. But I get it.
If they really wanted to do that, they should have a chat with Hopkins and University, and then they should come in with an agreement to the commission to say, we're going to temporarily send all of our orthopedic cases over to University, and let's make a deal with University, and we'll come in and we'll get an adjustment with the commission for those cases.
I'm not challenging the policy. I'm just saying education in this one seems to be unusual outcomes. So I'm not challenging that.
No, it's. I already got questions about how we calculate the cost from several people, so it's not clear yet that we are using a single price based on the AMC charges, which will be fixed during the year.
But I think it would be important to do some general education about low-intensity cases, not being sent there to deter them, but in cases where you just don't have coverage for those patients.
Right, to say you should come in, you should go talk to Hopkins and University and come in together, or you should, if you're Frederick and you're right next to Shady Grove or Adventist, you should talk to them about handling the cases for a little while until you replace a doctor, instead of sending them over to Hopkins and University and running up the bill.
People love the
And in the principles, we made sure we have the principle of unique circumstances. I think this may qualify for a unique circumstance. If that's the case, to evaluate and make sure the transfer policy or the measurement is not picking up something that we already discussed earlier.
Right. So if we did have a whole bunch of low-intensity cases come in from a particular hospital, we could work through it as a special circumstance.
So what we've been doing in the past several months is trying to hone in the measurement, because we use the case mix data, linked it with the CRISP, patient IDs, and trying to validate whether the algorithm and the IDs are linking up correctly. We send case level data to 22 hospitals and 2 AMCs for reconciliation. In terms of sending hospitals, you'll see the detail in the paper. In general, the agreement is quite good, 2%. So they said 2% of the cases that you're telling me transfers are not transfers. I don't know if it is worth doing this all the time. We may need to kind of agree on, okay, 2% is a tolerable level, except one hospital which has higher, so we are going to work with them. And then on the AMCs, so the one hospital actually I must have written there, Sinai. So if you take it out, it's 1%, it's even better, right? So we're going to work with Sinai and the 2 AMCs to kind of try to get those straightened out. On the university side, I received additional 30% additional cases that they told me you don't have these transfer cases in your data, and our data indicate that these are transfers. So when I try to match it back to my history files, I really cannot find any transfers except 24 cases, which I know the issue. I couldn't find any transfers of these 1,300 additional cases I got from university. And the reason why the number is high, because they send me everything. It's not like they send only other hospitals. They send transfers coming from out of state, coming from other systems, and also not only from the ED, but also they may be coming from the clinics. So that was the kind of the big number, and we are trying to narrow it down. There are cases where the CRISP ID is missing, 120 cases. So that's an issue I think we need to explore more to make sure CRISP ID is working as we think it is working. And once we resolve that issue, I think the data is ready that we could produce the base year and the performance year using the algorithm. Any questions on the data? So in terms of update, the plan is to do a January to June base year period, and then when we are discussing the market share, obviously we need to consider how we will handle the transfer cases and not double count them for shifts. I think one of the principles was we wanted to wait until the data was clean, so our base period is moving as we are taking, it's taking time to clarify. Right, right.
Okay. So now we're moving to the next topic, which is market share adjustment. And I think the major thing that we were focusing on doing today is to talk about some of the principles and to discuss the principles that might be applied when accounting for market share changes. But also, we have been working with the data and sharing some information and progress with the sub-work group. before we start into the detailed document, I just wanted Julie to take a second to talk about where we are in the data analysis and the data sharing process that we're undertaking so that folks can get some data to look at to do modeling with us.
So we've been looking at the service line, product line specific trends, and we thought it will be good to give the data to those who have resources and interest in looking at that on their own and trying to model alternatives. We will be providing fiscal year 13 and fiscal year 14 inpatient, outpatient, patient level data, which will have the patient IDs on it too, so you can count the services or you can count the patients. It will also have the weights that we developed, both for the inpatient and outpatient, and the documentation will be also provided in how we develop those weights. So our hope is, kind of one is to do some modeling looking at the year change, but also helping us in terms of whether the product line classifications make sense from the clinical perspective, and also the weights and other things that have in the data. One critical element in these data sets is observation cases. In the market share analyses or looking at the utilization, as you know, observation shift to the observation creates a challenge for us to be able to see what is happening. Is it really inpatient admissions declining, or are they just going to the observation? So to remedy that situation, we added observation cases 24-hour or more to the inpatient data. We are treating them as if they are inpatient cases. They have their APR-DRGs, they have their weights based on whatever the APR-DRG that they have. We haven't done any specific weighing for the observation cases yet. So that's something we would like to explore a little bit, but for now, all the observation cases 24-hour or more are considered an inpatient case. So that it cleans up a little bit the trending when you look at hospital by hospital. I believe those who are in the subgroup for the market share received the information about, so there is a DOA process you need to apply. It's an expedited process. You need to have a record of agreeing the terms of using the data. Once those are all filed, then we will be sending the data to you, hopefully by early next week. And I think that's the update. So do you want me to?
Yeah, I think that would be worthy. Just I think as we get ready to start into the principles, that it's important, at least for people to understand that we have started diving into some of the details, and other folks might decide that they also want to get the detailed data subject to the DUA requirements.
So I apologize to those who are online or on the phone. I literally created in the last minute, so I will send it to you after the meeting. So what I'm showing at the meeting is the service product lines that we created both for the inpatient and outpatient, and I sorted it by total charge column so you can see what are the major product lines in this stage. You'll see that the PAUs, the treatment of PAUs for the inpatient side are different than the product line description. So we separated readmissions and PQIs, and regardless of what product line they fall in, they are grouped together. So readmission line could be cardiology, could be psychiatry. All those readmission cases are pulled together as a readmission product line. Similarly, for the PQI too, any case that has one of the PQIs, that is also pulled as one single product line. And as you see, since we are pulling so many cases, you see the readmission is actually the largest total charge in our product line bucket. For 15, 14, well, this is 13 data, so it's 14. It should be 14 billion. Mm-hmm. And then just you can separate this when I send it inpatient versus outpatient, but then the next largest one is the ED without observation product line. And the case mix index, I made a note at the bottom, but I wanted to pay attention to it too. You cannot compare the case mix index between inpatient and outpatient at this point. We didn't create the same scale for them, so they are not comparable, but you can compare them within each inpatient and outpatient bucket.
But we have converted them in some other analyses, but in this table they're not converted yet.
So we didn't do ECMAT. So the ECMAT rates are our converted rates, which we didn't do it yet. I mean, I didn't do it for the table. So I think, so we had, we presented this at the subgroup meeting, and there's a detail behind which APR DRGs are going and where. So we are working with that as well. The only change from that presentation, if you were part of that, was the separating the normal delivery. So we have now a separate bucket for the normal newborns. So we separated them from the rest of the neonatology.
I just want to make quick questions. So those first two lines are across what I would consider several product lines, or several types of services, several DRGs. But what I'm a little confused about, okay, so the ED with observation and ED without observation, so there's basically three, if I'm just quickly looking at this, three product lines that are multiple service lines.
4, readmission, PQIs, and
PQI,
2 EDs.
Yes. Okay.
Readmission, PQI, and ED, we separated the ED with observation and without observation.
When you're thinking about multiple product lines, are you thinking about disease categories? Because the outpatient really isn't grouped based on disease categories at all.
But for readmissions and PQIs, which are both inpatient, that could be several different diagnostic types.
Yes. It's heavily weighted by medical, but it is definitely has a lot of different product lines.
So then it would also then be safe to say that readmissions and PQIs have been removed from all the other inpatient lines.
Yes. Okay. Intentionally, so that when they go down, the hospital who causes them to go down doesn't look bad on a market share calculation. Or that some hospital who doesn't do any reductions doesn't have some special benefit.
And, at the end of the day, we would need to come up with a total number for market share, but the value of looking at the product line level is really looking at the trends and teasing out. You think that the market share is going to happen at the product line level rather than at the aggregate. So if there is no shift, just decline in one product line versus a market shift in another product line, you don't want to sum them up without looking at that underlying data. So we think that there is a promising approach looking at the product line specific trends.
Yep. Volume and weight, case mix times case mix index. So that's why we're coming up with a consistent case mix index to give it a weight.
So like you said that observation is 24 hours is an inpatient. So you just took those cases and ran them through the inpatient grouper to figure out where they would get. Okay.
And since we don't have, well, majority of these cases are medical anyway, so there wasn't an issue. But obviously, since they are CPT coded, surgical cases are grouped under the inpatient.
The readmission broken out by product line or separate page or something?
there was that separate readmission reporting that we are doing with the hospitals. There's going to be some detail over there too, but we can do it here too.
And we also will have flags on the patient level file. I'm not saying that we won't do a summary for you, Dave, but we'll also have flags on the files that we share back of product lines so that folks can challenge the data or challenge the methodology, and we can refine it that way by accepting challenges and fixing things if we find problems.
So that's something we can discuss. I didn't include them yet. So the outpatient PAUs, we have a very limited measure, which is the 30-day visit following in admission. The numbers were, small, so I didn't add it to this one. But we are revising those numbers as well. So based on the magnitude, we may add it eventually.
I'm sorry if you went over this. Can I ask some questions about the readmissions? Is this all-cause readmissions and inter and intra-hospital?
Yes.
Okay.
So I just thought it would be helpful in term as we begin to discuss principles that that you can see from a directional standpoint that we're focusing at a fairly detailed level when we start to look at market share analysis as opposed to some very high level approach to market share analysis. And I think we started looking at the data with TPR hospital data where some serious reductions have been made in PAUs, and it clearly supports the need for having some detailed breakout so that you don't reward a hospital or penalize a hospital that has made PAU reductions and reward one who hasn't. I think it does support that as being important. So that gets us over to the paper, mini paper that we sent out with some principles outlined. And the paper starts out by describing the market share adjustment as a part of a broader set of tools that link our global budgets to populations and patients, and outlining that one of the focuses that we have with this is to play a role in ensuring and improving customer service and high quality care. So the focus of what we're trying to do here is to provide a basis for changing the global budgets of hospitals when their market share changes. So if they have an increase in market share of increasing the global budget, or conversely reducing the global budget if there is a reduction in market share. And there are lots of challenges in trying to develop an approach. One that we've just talked about extensively is the issue of hospitals that are being very successful in reducing avoidable utilization. Another problem that we have to contend with is making sure that we're not just picking up volume increases and awarding market share adjustments for volume increases, because that would undermine the whole reason for having a global budget if a volume increase equaled a market share adjustment. And of course, we want to make sure that we're not just responding to random fluctuations in volume as well. So when we get down into the next paragraph, we start to lay out what we thought should be some principles, and we'll start taking comments and thoughts as we work our way down through here in terms of the content as well as the principles. But in terms of a market share adjustment to be consistent with a population-based approach, we're focused on that it should be related to a specified population from which the hospital's market share would be calculated for a defined set of services, and also that to the maximum extent possible that we would focus on budget neutrality and or making sure that the market share change demonstrated higher quality. But really focusing on a budget neutral situation resulting from the application of market share. So, Hank, that means that if we took all of the cases from Anne Arundel Hospital and we put them all in university, that wouldn't result in a budget neutral adjustment. So we would be looking for some way to neutralize that. And that's not going to happen, but that's the concept of budget neutral, is making sure that if we're putting money in one place that we're gaining it from another place. So those are some principles that we've outlined there, and also that we should not hinder the elimination of marginal services.
The second bullet that says a defined set of covered services. What do you mean by that?
Well, I think there are some folks who were really driving the thought process for market share to a very high level, so that we would be looking at, say, the total volumes for a hospital as an indicator of market share. And so we started having trouble with that concept, because if Meredith doesn't have open heart surgery, but if we drive the product line definitions too high, we could suddenly start seeing that they were having a negative market share adjustment because their cardiology volumes went down and your open heart surgery volumes went up from their zip codes. And so we are focused on making sure that the service definitions are defined in enough detail so that we're not taking money from a hospital that really didn't actually lose anything in terms of market share and give it to a hospital that had a volume increase. So I think that we're hoping that by having some, we're starting along the line of product lines to help alleviate that problem by using product lines, so that we're looking at, so in a more direct case, what if your OB volumes went up? I'm just, you're in the same market. Your OB volumes went up. Their med-surg volumes went down. We don't want to call that a market share adjustment. It's not a market. From our point of view, that is not a market share adjustment. So that's the point that we're making with that definition. Now, if you disagree with that, we're willing to hear it. But that's really the point. You're asking for clarification. That's the point that we're trying to make, is that growth in one service line and a reduction in a different service line is not a market share shift. So that's a principle, but we're open to hearing alternative points of view.
I think that's consistent with a principle that suggests you only be rewarded or penalized in the service lines that you produce, that you have in your hospital. That you have to disaggregate it enough so that you have consistent rewards or penalties across the hospital that's gaining the market share and those that are losing the market share, and how you move the revenue. I do have a little bit of a problem, though, with the first point there, in that if you I don't know if this is the exact definition that you're thinking of, but if Hospital A has a market share in, say, where 85% of their patients come from, and you list out all the zip codes, and Hospital B might have a completely different set of zip codes, a neighboring hospital, but there's certain zip codes where there's not an overlap and some that there are. And the question is how we define what that specified population. Do we use 85% or 75% versus even statewide for the purposes of defining what each hospital's market share is? Because at any given time, you might, from one year to the next, have a different mix of the zip codes that make up your primary service area or the population for which a market share adjustment perhaps should be made. So I think that one in particular is one I think we're going to need a fair amount of discussion and consideration when we look at the data, because I'm not sure that those service areas for which you're defining the population, defining the market are necessarily consistent from year to year. And so we need to see where from looking at the data, where that overlap and change may be.
Yeah, I think statewide service area is one that the HSCRC staff is not, is not excited about at all, because it doesn't really relate back to a population. And although in the same way that Shule was able to come up with a virtual patient service area that took all zip codes into account, Shule is looking at the possibility of using virtual patient service areas for market share analysis for the non-TPR hospitals. For the TPR hospitals, where we have small cells, I call the zip codes are small cells in the TPR hospitals, we would probably not use a virtual patient service area because the zip codes are too small to apply at a zip code level. That kind of a thought process, but we may be able to use virtual areas in zip codes that are adequate sized. So we're still in the exploration approach of seeing what we can do in urban areas in particular to account for that. And we recognize that the academic medical centers have market share in every single zip code across the state. So we recognize that we need to deal with specialized use as well.
So Donna, a lot said about this market share, what the primary service area, the market area is, whether it's 75 or 85. Just to help me understand this, what happens to the other 15 or 25%? Because I think that's important in people's thinking about this, because maybe there's not going to be much of a disagreement. But if you're going to draw the circle and you're going to pick up 85% of their market, how do you address the other 15?
So in one world, you wouldn't address it at all. So you just look at the top 75 or 85, so let's say 85%, you'd calculate a market share adjustment using the algorithm. You'd add all of the market share adjustments up statewide and hope that they balanced out. So in the grand scheme of things, they would probably balance out within reason, even if you didn't account for that last 15%.
So it would sound like, I don't mean to dramatize this, but it would sound like you're basically saying hospitals, they or your borders do not cross. Because if you cross, I'm not going to reward you. Even though that you can provide services to that community, I'm not going to let you compete for that. I don't want you to reach that far. I don't mean to exaggerate and dramatize it, but I'm just trying to understand the arithmetic here. Is that, maybe that's not the message you want to send, but that's the result of it. Yes? No? Think about it a bit.
We haven't analyzed the last 15% to know how much movement there is in the last 15%.
Right.
And when we analyze it, if we think it's important, then we would, or if there were a special situation, then that's a different issue. For most hospitals, their 85% service area, while there might be a little bit of flipping on the edges, it's a fairly stable situation based on my experience. But
yeah, I agree with you about that. And we have seen hospitals reach into other markets over the last few years and pull market share.
Well, maybe it would get to one of the some of the principles on the next page. So I think one of the, for example, one of the things that we're focused on not reinforcing. So we don't want to provide we do not want to encourage the acquisition of physician practices outside of a hospital service area promoted to increase market share. So we are definitely, this commission staff, and we'll listen to input, but we're definitely not focused on providing an incentive program to promote acquisition of physician practices outside of one's primary area to enhance volumes at the hospital.
I can give you some comfort there. At 50% variable cost factor, I don't think you're going to see a lot of that.
Well, that's part of what the 50%. That's what the 50%. The 50% is all about that. So if unless somebody discontinues a service in that 15% zone, unless somebody else discontinues the service, if you don't go out and buy a physician practice, the chances of having some major influx in that last 15% area is kind of small, except for the academic medical centers where you have specialty cases coming from around the entire state. The last 15% service area that's outside of the reaches of your normal service area just isn't going to pound through a big market share changes unless somebody discontinues the service or you buy something. So if we don't do a virtual patient service area, if we do a virtual patient service area, we would pick up everything. If we don't, then we'd have to see what happens in that last 15%. But if we're having changes due to physician practice acquisition, we won't be highly motivated to reward them, and we won't reward them at a 50% rate, as you said.
Donna, on that issue, are you talking about outside the 85% or 75%?
Yes, outside of the 85%.
That was my clarifying question. But then, how is that any different? Say you acquire a physician practice that has some sites that are outside your primary service area or your service area, and you spend some money to do that. How is that any different than buying a piece of technology that costs $5 million and attracting volumes from outside your service area? So I think if you're going to do that,
you're not adding any new capability for the community benefit. If you're investing in a new technology that's better, you're adding capability for a community benefit.
And you're reflecting, you're saying for an add on the market share, but what happens if you're using those patients to essentially keep your prices down? You're not trying to increase your global budget.
Then you shouldn't be looking for an adjustment from us, and you'll say.
No.
Yeah.
So you wouldn't say that. Okay.
I'm not telling you not to do it. I'm just telling you we don't want to reward you for it. Anyway, that's really
more of a time dimension, though. I mean, you know, if Hank's reaching out beyond his current 85% service area and is very successful in, from whatever he's doing, buying physician practices or whatever, then at some point in time, when it's time to take a look at what other types of market share adjustments are occurring, he's going to have a different service area. His 85% service area is going to be different. The zip codes that are now in his 15% zone may actually become part of his 85% zone. So over time, he could actually do quite well by doing that. Well, it's not going to be immediate reward, but if we're periodically, you know, readjusting the market shares, how we define market shares, which we will be doing.
Right.
So I want to, I agree with the mechanics of that. I want to get back to 50% variable cost factor, because you made the comment you don't want to reward hospitals. I want to make it clear to everybody, getting paid 50 cents on the dollar is not a reward.
Well, that's actually part of the way of making sure that we're not focused on driving physician acquisition as a way of achieving market share.
Well, but you may also find that that's already exists, and programs like orthopedics or cardiac services already have reaching marketing programs in a lot of the outreach. Now, I don't know if it's enough to be significant to the 15% side or not, but I think that I just bring it up that it's not about, it can be about the existing patterns of business practices that hospitals already have in place, and not creating new capacity through acquisition.
Right. I mean, there's already past acquisitions, and those have already shifted market share in large measure. So we're talking about future shifts.
Yeah.
So,
Donna,
go ahead.
Is the 85% across all product lines and service lines?
We
or
haven't
are you
said
thinking
that yet.
about
doing
it at the product line? I'm thinking specifically to some of the services that are more regional in nature rather than community-based, and just what you're thinking about that.
I don't think we've gotten.
Okay.
We haven't gotten that far, but we are still looking at a virtual patient service area, which could go above 85% as well if we can make the math work correctly and there's not too many small cells.
And there was also discussion about maybe for certain product lines there could be a different primary service area, but our approach in general, given how many product lines we have, to have at least a fixed zip code level so you don't have to worry about too many changes between product lines. So I think it will be everyone's benefit if we can have a kind of a consistent zip code list for majority, if not all, product lines in the calculation.
Okay, and just to clarify, we're still talking about Maryland residents having Maryland services. So all of those border cities that folks cross over to D.C. or West Virginia or Virginia or wherever they go are not included in the market share. So if something changed and your referral pattern changed for whatever reason, then it's a come back and talk kind of thing.
Yes, you know, if we get the Medicare data more timely, out-of-state utilization, we'll find a way of looking at that for particular hospitals. Yeah.
And ultimately, the APCD database and the Medicaid data, when we can get that data on a more timely basis. But if it's 8 or 9 months behind, that's not terribly in arrears to do a market share calculation.
How will this process take into account changing therapies or technologies or practice patterns, and will you be able to reward early adopters, or I mean, how does that factor into any of this? I mean, if, for example, somebody comes up with a miracle cure for heart disease, and you still have some hospitals doing open heart surgery, how would that play out there?
Right now, we're not thinking of addressing volume changes, whether it's a new technology that creates a new service line or a new technology that creates a different way of doing something. Right now, we're not focused on how to address that with a market share adjustment because it starts to slip into giving a volume adjustment for new technology, and that slides into an area where it may be very appropriate for us to come up with a policy to say we're going to fund this new technology, but we don't want to do it with a market share adjustment. We want to do it with a policy recommendation that's specifically related to a new technology. So we wouldn't want to say, for example, and not that this is going to come through this way anyway, but well, hepatitis treatment is in here for a particular DRG or outpatient service, but we are going to take money away on a market share adjustment for hospitals that have hepatitis treatment and give all that money to hepatitis drugs. So we're not ready. That's too much of a policy adjustment for us to take on with a market share adjustment, and we're not ready to put technology policy into the market share adjustment. Does that make any sense? These are the ones that we've come up with, and we're open to suggestions. So we're giving these out. We're going to let people look at them and kick the tires. We've already made one adjustment based on input, and that's to split out low birth weight babies, and we'll be open to combining or increasing the number of product lines. The product lines were based on, for the inpatient, were based on the APR, DRG product lines from 3M plus a smattering of the product lines from the University Hospital Consortium so we could get some more granularity. And the outpatient product lines were based on the analysis that we've had in terms of looking at how Milliman and consultants break out and health plans and consultants break out their outpatient business. And also consideration of shifts issues, of things that we might want to have broken out for looking at shift. So, so that was kind of driving our outpatient product line. Those are how those were arrived at. And then PQI, then the PALs, we were also trying to break out the PALs, so that's what we were doing there. But we will be open for input. So I think we got through three so far, three show me where we're looking. Are we looking on page 2?
First bullet.
Page 2, first bullet, marketing strategy. What are you getting at there? How would you
Well, maybe we should reword it if it's giving you a little bit of chest pain there. And, physician acquisitions, practice protocols, etc. So we could reword that.
Or is it linked to incentives in many older physician arrangements where they got inducements if they drove more RVUs or visits or admissions to the hospital?
Well, they don't do that.
Well, no, but there was, in terms of measuring, I'm saying some of the older contracts may have done that.
Yeah.
Particularly in particularly if you're putting inducements in a specialist contract to bring referrals into your area that are not necessarily, not of your service area, and they're just, taking volume from somewhere else.
So
I don't know that a lot of people were doing that. Dave, I don't know that a lot of people were doing that anymore.
You can't do it.
Mike's right. There might have been some older contracts that did that.
I mean, the oldest example of marketing strategies is putting the Medicare Advantage enrollment office on the second floor, so that people who can't get up the steps can't enroll. So that's so we're looking at, for an example, if a physician contract was only net billings, you could, or net collections, you could view that as an inducement not to take care of uninsured people, for example. We also have the issue of acquisition, but in this instance, we were looking at ways to restrict care. So marketing approaches, the most unique Medicare Advantage marketing approaches are some of the examples that one could think of, and I won't put any great ideas in your head about restricting. Fortunately, I haven't seen this in the past in Maryland hospital behavior, but we're allowing that it could happen, and if it does, then we're so we're saying that this is examples of reductions in utilization that undermine the achievement of the triple aim, and that is avoiding unprofitable services and causing people to have to go elsewhere. So that's a reduction that we would we would want to make a market share adjustment if you did that, as opposed to a PAL. We don't want to make a market share adjustment, but if you do something to restrict services, we want to make a negative market share adjustment. So we were putting here examples that would undermine the triple aim.
Hey, Donna?
Yes.
Mike Curran again. I understand all that, but is there any way of working in some of the positives, like I was discussing earlier? For instance, if people are making or over-investing in new technology or care patterns to reduce it, they should not be negatively impacted. And the reason I raise it in comment 3.6, again, it talks about legitimate things that you'll reduce for, but it's a lot easier to talk to the clinicians if they realize by doing the right things and adopting new care patterns, you're not going to be negatively impacted. It's an incredible motivation, and I wouldn't want to see us lose that.
So under things at the top that we talk about, in addition to talking about what we are doing fewer of, we should add something about what we're doing more of.
That's correct.
In terms of desirable approaches to improving care and lowering costs.
To give you one example, we're looking at a piece of technology that we can place in the home to help monitor diabetes, and I'm sure there's others that are doing that as well. We want to encourage those level of investments and, again, not have the physicians and clinicians think that those type of investments may hurt them economically.
Right. Okay, we can add some of those to the write-up.
Thank you.
Mm-hmm. If I could, before we go further on, because I had a question on the first page of the document, and it's in that second paragraph talking about the encouragement of movement of services from low value to high value providers of a service. And I guess I just want to know who's defining high value, low value, how that's being defined, if that term is currently used. That was, that's just a big concern. This is, where is this? What is, just, how's this being defined? Have we used this before in the state of Maryland? And
I get calls almost every single day from people that are trying to interest me in steering people to high-value providers versus low-value providers. I'm having breakfast tomorrow morning with somebody exactly making that pitch. Whether or not there's merit in what they're selling and the algorithms, they reach those conclusions. Whether or not I could convince people in my population to make that kind of move is another thing. But I mean, that kind of thinking is very, very much out there.
And I appreciate that. I know that thinking's out there. But I guess I still get to who's defining that and, how is it being used?
Well, we do have a performance measures work group, and they are really at very early stages in being able to develop value equations. So, so I think we say ideally, and I think we're quite a ways away from a point where we would be prepared to say A is more valuable than B. We're not close to a point of being able to say that. On the other hand, we do have to think when we get to the balanced budget or budget neutral aspect of this as we get down the road and we start looking at the data. If market share adjustments aren't balancing out on a relatively revenue neutral basis, there are those who think that we should calculate market share adjustments and make the transfer at a standard price, so that if we're, instead of looking at a variable rate for each hospital, that we would have a standard price in a service area, and we would use that to make an adjustment instead of making an adjustment based on the rate of each hospital. So those are some thought processes that have arisen. We haven't gotten to the calculations yet, so we're still figuring out how to make the calculations, and then we'll be able to move into that conversation.
And if I may add, this is kind of the inspiration for us to really reach to the value, but you can think about a market share policy not rewarding for a hospital with a low quality, high cost to gain more market share. I think our long-term thinking is, for hospitals, if they are looking at their strategies, you may have two options. This is very simplified, but one is to go and try to get more market share. The other one is to improve your quality. And if you have if you're performing already low, the strategy, to me, we need to make sure the incentive is for them to improve their quality first rather than trying to get more market share to a hospital where the quality is not at par. But it's not here. This is kind of our, as I said, desperation.
I appreciate that this issue is probably one of the more difficult ones, and it's probably also an overstatement for me to say that in a truly patient-centric system, if that is our ultimate goal, the value is defined by the individual patient and the choices they make to which providers they choose. And so what I think we're trying to say is we don't want to put any barriers in the way of the patient making those kinds of choices. But I will say one question that I'd like, and it may be just something that we can't answer right away. We are going to have some communities, particularly as we look at smaller hospitals in more rural areas, where the patient will always want to choose their local facility, even if because of the numbers they appear to be high cost, because of the way in which we've reduced utilization or other things in those communities, they still want to have that choice. So that value equation may work differently for each patient in each community depending on how they would evaluate the cost as well as the quality. They may opt for and want to have choice of a high cost and low quality facility as we know the measurement, because they may have a different way of valuing the quality and the cost. So I just want to put that out there, that if ultimately this is a patient-centric system where we're encouraging choice, we don't want the market share adjustment to be a barrier for that, but we have to be careful as to how that works in each community.
I'd like to just comment to that. This is Ann Mack, because we're getting into an area where it's very difficult to quantify and measure. And while we do want to make sure that hospitals adopt the technology that really improves care and ultimately drives down cost, we always have two issues when we adopt technology. One is to try and recoup the cost of investment on that technology by inducing demand. And also, there's a quandary that we get into as healthcare providers, that when we start to use technology that is more efficient and effective in care and safer, we sometimes then start to use that technology in more cases, and we begin to get into a gray area crossing in terms of where patients really need that care versus patients wanting that care, where there may not be the indication for that. So I think that's the quandary to look at, and I'm very glad that we're going to be looking at this in the light of global targets so that we don't lower per unit cost of care by increasing technology, but increase the overall volumes in doing so, because it's so much easier to use and safer to use that technology.
Donna, since you've considered creating these virtual regions, and you have lots of caveats in here about not rewarding growth and volume, have you given any consideration to injecting use rates, admissions per thousand, ED visits per thousand, et cetera, into these calculations to determine if the increases in revenue or volume are driving use rates up? I mean, there's been a lot of discussion about driving use rates down, and use rates in Maryland are high. So is this an appropriate place to give that consideration?
The issue of whether we should put use rates into the calculation goes to one more level of granularity. And so I think if we have service line and we have zip code and then we have age cohorts, what we have to worry about is really getting into a lot of small cells. So I think in the end we could do more use rates if we aggregate service areas, or if we disaggregate to zip code levels, then we may find it hard to include age in the calculation, because that would really create a lot of small cell size. So I think it's possible to do use rates in the calculation if we don't have small cell size problem.
We've gone to a lot of granularity to define PAUs and other types of services, although they are easier to define, I grant you, because you have APR, DRGs et al. That you can use. But we are concerned, we're talking about the total cost of care back to its price and volume is reflective of use rates, and use rates in Maryland have always been very high. And I've sat at these meetings for a number of years where, driving down volume was a hallmark of the discussion.
Well, the use rate issue gets a little cloudy also when you get into the service line. So, for example, one might project, based on the aging population, that medical services would go up in the state. However, because we have an aging population, cardiology should go up. But if you actually look at the data, cardiology is going down because we're getting rid of PQIs, we're focusing on keeping nursing home admissions down. So if you start building it into some formula to project what the use rate is going to be based on the age of the patient, then you end up with a wrong projection because we're actually going in the opposite direction on the aging front. Right now we're having more reduction in use rates for the older population. It definitely helps. There's still a lot of noise in the medical volumes, I'll tell you. There's still a lot of noise that we haven't accounted for with the PAUs in some of the medical categories.
Yeah, but you'd be overlapping the two in some ways, right?
Unless you're buying a new technology that drives unnecessary use.
I'm just saying that you don't shrink the market. The use rates are up. It probably is because PAUs are high. So how do you eliminate the double counting of that issue?
Well, it shrinks the market, so as you get rid of your PAUs, you're shrinking the market.
Actually, probably part of the issue goes to what we have in the formula on the last page of what we would call a market share adjustment. And so this gets into the issue of whether you're looking at a use rate. And so on the last page, we've outlined some preliminary thinking on what is a market share shift. And so basically what is outlined there is that in order to have a market share shift, you have to have an increase on one hand and a decrease on the other hand. If you have two entities and they both have volume decreases, that we're not having a market share adjustment, even if one of them now has a higher market share than the other. If they both had a decreased volume, we aren't awarding a market share adjustment in this calculation. So I think that gets to the And when we say decrease, that's a decrease that is greater than the decrease in Hospital A. So meaning if Hospital A has a decrease of 100 cases and the market area has 200 case decrease, that's not a market share shift. But if there's a decrease of 80 cases, meaning that it's all Hospital A that went down and somebody else went up, then we are focused on calculating a market shift. So then we're looking at if there's a volume increase in Hospital A, a volume decrease in the rest of the hospitals in the service area, then we would award a market share adjustment. If there's a volume decrease in Hospital A and a volume increase in the service area, then we would award a volume decrease, market share for volume decrease. So those are the math formulas that focus on use rate concepts without actually introducing the age into the calculation. But these are the use rate concepts, Ray, that that we're at least thinking about that that might keep us from getting into as much granularity as age adjustment would.
Can I make a comment? I'm sorry. I'm going to just toss this into the something to think about idea.
Okay.
And that's the shift from low volume to high volume, or low value to high value services. Take out the providers. Got me thinking that there's a big emphasis on value-based insurance design in the state right now, and a emphasis to incentivize providers or patients to use different services which are more proven to be of high value. So, for example, spine surgery for lower back pain versus rehab therapy and things like this. And to the extent that there are these incentives to move people to higher value services that might cross service lines, that there might be something just to be aware of and to look for when you're looking at the data. So just something to think about.
How do I read the sub-bullet that tells where it says ABC decrease greater of absolute value? How do I?
Basically, that's saying, okay, if you have, let's say you have a volume increase at your hospital of 100, but the volume decrease in the other hospitals is 30. So you only get 30. You don't get 100. So that's what that means. So if it goes up 110, you only get 100. If you go up 100 and they go down 110, you only get 100. If you go up 100 and they go down 30, you get 30.
I'm going to get the lesser of my increase for their.
Yep. So that's really what that description is showing.
Same for the decrease.
Yes. Mm-hmm.
So what was the decrease?
Okay.
So if you decrease more than what the other hospital gained, we are just adjusting for the gains in the other hospital.
Okay.
Because we are assuming the other one is the utilization decline, which is under your global budget.
And David has written up the math formulas to put this into the big box to make the calculations. David Romans has constructed our math formulas for us.
How is the PAUs considered? So an example that's not here would be Hospital A's volume decreases because of PAUs, and the rest of the market stayed the same because they weren't as aggressive on PAUs.
So we are excluding the PAUs from the calculation. We'll still look at them, and if there's somebody who says, oh, Kaiser Permanente comes to us and says, hey, guess what, I moved all of my cases from Meredith to Frederick, then there will probably be some PAUs in those cases, and so we would take a special consideration on a PAU adjustment if there was a big movement of cases related to a payer-driven approach. So that's really
absent that, is that what was trying to get at 3.8 here on the guiding principles? Market shifts and potentially avoidable utilization should be evaluated separately?
Mm-hmm. Yes. So that's really, there's a footnote there that talks about Kaiser Permanente, HMO. The other HMOs in our state mostly don't shift so much, but Kaiser does sometimes do big shifts. And I wasn't picking on them in particular, but
and I think though the one question I would raise there is we are also going to have separate policies like we have on readmissions, hospital avoidable complications. We might eventually do one on PQIs, so that the concern I would have is that we not have double rewards or double penalties for that same thing, that we not have a market share adjustment for potentially avoidable utilization and then have a separate policy on potentially avoidable utilization that has penalties and rewards. So I just think as a matter of principle, we need to think through that one a little bit so that they're not double penalties and double rewards, unless that's a policy you want to set to absolutely, if you will, penalize hospitals for potentially avoidable utilization, that they see it in more than one place. So I think that's a principle we need to explore, that it not be duplicated.
My last plug for use rates is that if you're just looking at shifts between hospitals, you're not considering the overall use rate of a particular area. And I understood your comment about granularity. Like, you can't do use rates by service line effectively, I would imagine. And that's probably one of your hang-ups. But you may be able, as you've created virtual geographic regions, if you create larger regions, perhaps you create, instead of APR DRGs, you're looking at MDCs or something. Perhaps you're looking at something, you're looking at combining some of those service areas. I only ask you to consider it.
what would you focus on as a policy? Could you explain to me what you would focus on as a policy?
What you would want to see is overall use rate declines, would you not? Because you're beginning with a higher level of volume that you think is unnecessary.
So are you saying if there's not a use rate decline in the service area, we shouldn't award a market share adjustment?
You might say something like that, but I don't know that I would make it that definitive. But certainly, if you're looking at reducing PAUs, PQIs, and readmissions, you should see declines in use rates.
Right, but just to be devil's advocate for a minute, that should show up in your volume drop for the overall market. So I think that would be captured. It's like you giving a target goal, which I don't think we would get into. But if everybody in that market did better on PAUs, there'd be a whole lot less admissions, so your market shrinks. And you may maintain the same percentage, but it's of a smaller market. So I think the volume decrease, number 2, would capture that use rate drop. So just think about it. That's just a thought. And while you're thinking about that, can I speed up the value one more time? Because I know we keep bringing it up. And I think this tied together of what everybody has said here, Mike on the patient choice, and then also just the stigma of what it means to be low value to high value, and how do we actually define that. For example, Frederick, NICU. It's high value to the family to be able to stay in Frederick and not have to travel to Baltimore. There was a recent change in birth weights. We've resolved it, and now Frederick will start taking care of even a little bit lower birth weight in the community. And I think that that's high value, but we should be much lower cost than would be one of the AMCs or a children's hospital that might have been transferred to. A similar program to me is also catheterization, the Seaport program. In the beginning, you could go, gee, these hospitals don't do that. They don't show the value. But over time, the research showed that it worked out that Seaport in the without the open heart backup actually was valuable, high value. So I don't know if it's a rewrite or I take it out or whatever. I think our definition of value is subjective to some degree based on the individual situation.
I think part of that statement actually started with the comments from the payers, and what they were focused on is not rewarding physician acquisition. So it may be that we can work on rewriting it because we don't want to create a concern around something that we're a long way from being able to do. So there was a sense that, you know, from that comment from the payers that we wouldn't want to create a structure that encouraged high-charge hospitals to acquire physicians and take patients away from lower-charge hospitals, and we turn around and reinforce that with some policy that we were adopting. So
maybe the value word, because you think of value in such a broad, important way,
that we should think about it as a long-term strategy, but not causing folks to get heartburn about it from a here and now.
It's the encouraging movement from a low value and what is. I mean, I understand the issue of you don't do enough volume, you may not have the right quality outcomes. To me, that sort of value. I feel like this is maybe saying to say we're going to have a policy that encourages moving services. I'm not sure.
Yeah, it's not saying we're going to have a. It's actually, it says in ideal world that's right. So it's not. So we can reword the sentence a little bit to make it clear. And also, I would say, would it be better if we say high quality, low cost? Is that?
I mean, I'm going back to what Donna just said. It just seems like it's raising so many questions in a lot of people's minds, and I'm wondering if you really need that sentence here.
Well, let me argue for including the concept of value, because I think it's really important to put it in there. This is a set of principles, and I think a set of principles that doesn't have the word value in it, I think, is missing something. I think what we can do is maybe define what value means to us and include some of the things that have been raised here. You know, convenience, it's not only price and some, you know, objective, apersonal metric of quality, but, you know, it's a combination of clinical quality, convenience, and better outcomes for the patient. You know, you can elaborate on that, and that way you're putting value on the table, and you're saying, you already say, you know, it's going to need, how we measure that is going to need to be, or how we operationalize it is going to need to be developed. But I think it's important to have value in there.
And I would say maybe it's the encouraging movement versus supporting value. Might be small. I don't disagree with keeping value in there.
Maybe take out high and low. You know,
yeah.
You could say, you know,
support value.
Support value and quality. I don't know.
Well, you know, I
kind of the high and low. What?
Yeah.
Well, I actually think when we get on the guiding principles page, it has it there, and recognize that it will take some time to flesh out exactly what we mean by value. So I have no problem with it being in there in a couple of the places that you have it there.
So low value is very subjective, and I don't like it.
Perhaps the word should be rewarding higher value. Going back to Mike Curran's earlier comment for the promotion of greater value.
Continuing to improve value.
I like promotion of greater value in the system because that embodies.
It's a more positive kind of a message.
There's at least one or two things we can agree on.
And to perhaps say to encourage, you know, the value of providing high quality service to patients who truly need them, and that would get at the issue about having the NICU conveniently located so that the parents can visit their child, but would also make sure that we look at are there clinical indicators for doing procedures, so that we're not just lowering the bar for doing procedures because they're more efficient and more effective.
Okay.
clinical indicators are crucially important when we look at volumes and quality. Are we doing services and performing procedures on patients who truly need them?
Right.
And I'm thinking in that of the Dr. Madai scandal at St. Joe's, stenting people with 10% blockage.
Right.
So can I just add one information I quickly said but didn't emphasize? In terms of the use rate analysis, the other approach we're looking at is actually a patient-based utilization measurement rather than a service count. So maybe there, eventually we may find a way to really look at the patients rather than number of services that they are receiving in the hospital. So we are working on that too.
So that it continues to be more population-based in terms of looking at market share. So what percentage of the patients are you taking care of, as opposed to what percentage of the services are you providing? It's not quite an attribution, but looking at number of patients served in different categories. So it's something that we've done some looking at, which could, when we get into market share in urban areas, it's pretty interesting problem. Some of the urban institutions only have a 5% market share of a zip code, so it's gets to be a little bit more dicey. And so then when we start looking at patients and their movement across, that's an area where we might focus a little bit. Right. So that is an area that we've started to give some thought to as well. So I realize that this is kind of the first time that you've seen this paper and that you'll go back and look at it and think about it some more and bring some more comments to the next meeting. But I think at least we've taken a quick pass-through for a first time of looking at it, and we have some comments that we can take back and add to it and continue to refine it. And I think when is our next meeting, Jessica?
Oh. 29th.
So I think we do have a meeting on the books for the 29th. We're hoping to start to look at some more calculations and data. And also we have a request to make a presentation from Ken Thorpe on market share. We will have to confirm that, and also we will hopefully have a report from the GBR infrastructure reporting work group, so that we can look at what folks are thinking about in terms of reporting infrastructure for GBR and TPR hospitals. David has been working on Medicaid savings calculations, and we're hoping that we can see if we're at a point where we can estimate Medicaid savings from the new model. So that hopefully you all will get some data and start kicking the tires with us with the data as well. So that's some progress, and we'll take the comments that we've gotten so far and reflect them, and feel free to email them if you want to email comments, or we'll continue to take comments as they move forward. So thank you for your attention for sizable meeting.
Big drive,